It might be important to note the APM bonuses larger than those potentially provided by traditional MIPS are now going away. We used to get a 5% lump sum bonus on Medicare payments for earning qualified participant, that is QP, status in an alternative payment model. The bonus is down to 3.5% in 2025 and is based on 2023 APM attribution and QP status. It will go down to 1.88% in 2026 based on 2024 attribution and QP status, and starting in 2027, the incentive will only be a 0.75% boost to the conversion factor on the physician fee schedule. It might be advantageous to be a partial QP if possible and submit traditional MIPS.
Thanks, Steve, for the observation. I like how you think. You found strategic value in partial QP status. Now, I think the take home from this is not to fear partial QP or even non-QP status. There may be some advantages. I stop short, though, of recommending that you seek it. I don't think it's as easy as you'd like it to be to avoid QP status. QP status is indirectly a measure of patient engagement, which is pivotal to controlling healthcare costs, to access the gains in whatever alternative payment model you're in. And MIPS incentives are not as clearly better or easier to access than QP incentives. Now, before I explain those points, for those of you for whom qualified participant status is a new concept or still confusing, let me make an attempt to explain it. And when I talk about our alternative payment models, I'll talk about the Medicare Shared Savings Program because it is by far the most commonly used alternative payment model. But the principles I discuss are widely applicable to all or any APM. Every APM has a reward for healthcare cost savings, which is why, that reward is why you as a group are participating in the APM. Qualified status is granted to participants in an advanced payment model, that is, any model through Medicare's Center for Medicare and Medicaid Innovation. There's a threshold that you must hit to be a QP and a lower threshold to be a partial QP. And if you don't hit either threshold, you're not a QP. Medicare measures, to establish this status, Medicare measures your volume of Medicare patients. First, they take account of the unique Medicare patients you saw in a year. And second, they total the allowable charges you submitted for your patients in a year. Now, Medicare compares those numbers to the subset of those patients who become attributed to your ACO. There's a threshold percentage. Now, Medicare has been slowly increasing that threshold. For the 2025 performance year, the threshold is 50% of your allowable charges or 35% of your count of unique patients. If you achieve either of those thresholds for 2025, you are considered a qualified participant or a QP for 2025. Now, there are lower thresholds to be a partial QP and also lower thresholds, different thresholds for being a QP or partial QP in an all-payer model, but we won't go into that. For partial QP status in 2025, it's not 50, but it's 40% of allowable charges. And on unique patients, it's not 35, but 25% of your unique patients. Now, for any particular year of participation in an alternative payment model, you can be a qualified participant, a partially qualified participant, or neither. That is a non-qualified, non-QP. Now, and what do those statuses mean? If you're a QP, if you're a qualified participant, you have no MIPS liability. You won't get credit for a MIPS submission even if you make one. If you're a partial QP, you can choose whether or not you'll participate in MIPS. Ideally, you will submit MIPS if you expect to score well and earn an incentive, and you'll not submit if you think there will be a negative incentive. If you're a non-QP, you're liable for MIPS and will receive whatever MIPS incentive you earn. You don't have a choice. Now, whether QP or not, all participants will benefit from whatever reward your APM model applies for cost savings. Of course, the distribution of those rewards are subject to the terms of the participation agreement you have with your ACO. So, with that in mind, let's go back to the points I made about non-QP status. Now, it's not easy to avoid QP status. So if you find a strategic advantage to being a non-QP, it's going to be a hard thing to do. To illustrate that, let me go back to the most recent year that Medicare's published these statistics. That most recent year now is 2022. So in 2022, there are 420,000 advanced APM participants in the United States. 386,000 of them, or 92% of them, achieved QP status. 34,000, that's only 8% of them, were non-QPs. And only 300, that's less than a percent, that's about 0.1%, were partial QPs. Knowing the dynamics, I suspect that virtually all primary care providers become QPs. For those who don't, there's likely something very unusual about their practice. Maybe they have a set of non-primary care services they're providing to patients, maybe even on a referral basis, or they're unpopular enough that patients don't come back to them, which is necessary to end up being attributed. The dynamics of primary care practices and patients' relationship to their primary care doctors nearly assure that those patients will be attributed to those primary care providers. Now, I suspect that most partial QPs and non-QPs are in specialty practices, determined not so much by patient returns or patient engagement, but by their referral network. If you predominantly get your referrals from within the ACO, you'll more likely be a qualified participant. If you have a broader pool of referral sources, so it's only a small percentage lower than the threshold that come from within your ACO, you're likely to be a partial or a non-QP. Now, my second point is that it's not good for the ACO if you're deliberately avoiding QP status. One of the only ways to do that is to avoid seeing patients on a recurring basis or being unpopular enough that people don't come back, and encouraging people, therefore, not to be engaged. But if the ACO doesn't have engaged patients, it has no influence to promote cost reduction. And attribution, I would say, is a measure of engagement. If you're a primary care provider, low attribution is a bad sign. Now, my final point is that higher incentives available in MIPS are not assured by any means. In advanced APM, all qualified participants earn the incentive. That was true when it was 5%. It will continue to be true when it changes to 0.75% on the conversion factor. In the new model, a boost in the conversion factor means that all payments for Medicare services are higher, not just Medicare reimbursements, but out-of-pocket expenses for the patient. It means that in comparison to MIPS, the APM incentive is going to effectively be closer to 1% than just 0.75%. MIPS incentives are revenue neutral to CMS. They collect as much in negative incentives as they distribute in positive. So the average incentive of MIPS is designed to be zero. So there isn't an assurance that if you go for a MIPS incentive, you'll actually get one. On the other hand, on the advanced APM, everyone who becomes a QP gets the incentive. It's not withheld from anyone. It is that number. There's no graduating level, and there's no negative incentive if you don't become a QP. So if you end up participating in MIPS as an advanced APM participant, you're not likely to get into big negative incentives. I mean, the maximum negative incentive is minus 9%. And you're unlikely to get that. Even if you don't make an additional submission, your APM's quality submission, at least in the MSSP, that is the Medicare Insurance Savings Program, will count as your quality score. So you'll get the same quality score that you're as your ACO received, unless you make a different submission that has a higher score, in which case you'll get the highest of the scores submitted in your behalf. You'll earn 100% of your practice improvement points as long as you make any submission at all, as all APM participants do. You're not going to get a score for cost. Cost incentives for APM participants, even if they're not qualified participants, are built into the payment model. They don't come from the incentive. So you'll be forgiven from cost, even if you're subject to MIPS. And there'll be a CERT, the use of certified EHR score. And you'll either generate a score through your work with the APM, or you'll have an exception. So you'll either be forgiven from it or have a score. So overall, you're going to have an aggregate score that may land you in the negative incentive range, but it won't be dreadfully low in the negative incentive range. And the most important point being that it's not uniformly positive, as is the QP incentive. So thanks for this stimulating exercise, Steve. Great comment, great observation.